Thank you for allowing me to be here. It's truly a pleasure. And Dr. Foster's very sorry that he can't make it. He had a major, like Dr. Edelman mentioned, had a major surgery. He just turned 75 back in May and had a big surgery a month ago. He's recovering very well, and I have a video proof of that. And he's just very sorry he can't be here. I was trained by Dr. Foster many years ago. Even before my residency, I spent 2 years with him when we were still back in Cambridge, in Massachusetts. And after 2 years of that, I went out to do my ophthalmology residency at New York Eye and Ear Infirmary, then followed by 2 years of retina training in surgical retina under the direction of Dr. Bill Mueller and Jennifer Lim at University of Illinois. And last fall, I just came back to Mercy and joined Dr. Foster as one of his partners. So a pleasure to be here. It's my second time back in Florence. Last time I came here after I got engaged with my wife, and she's here with me today. And we were able to leave our 19-month son at home with grandparents so we can actually enjoy Florence in a real way. So we'll get started. Birdshot, always one of Dr. Foster's favorite topics because while it's not very difficult to diagnose, in our opinion, it's extremely undertreated. And that's what my lecture today will be focusing on. Well, here's the video proof that Dr. Foster's well. Oh, there's no audio.
I'll make it up to you someday. I'll be over there before too terribly long, and I wish...
Let's go back then. There we go. Thank you.
Hi, I'm Stephen Foster, and I'm sorry I can't be with you today, but I think you're going to enjoy what Dr. Chang has to tell you. I'll make it up to you someday. I'll be over there before too terribly long, and I wish you a very, very successful meeting.
Yeah, so that was recorded 2 days ago, and he's back eating a lot of fruits, and you can see in the background because he's on his road to good recovery.
Hi.
All right, so financial disclosures, non-relevant to this lecture here, but almost everything we mention here is off-label, just like most things in uveitis, as you may know. Now, Dr. Foster give credit to Dr. Karl Herbor in Lausanne, Switzerland for pointing this out. I know in general, Birdshot is sort of generally, the description of Birdshot was credited to Dr. Steve Ryan and Ed Mominay at Wilmer Eye from the 1980s. But Dr. Herbor Jr. May have pointed this out. This may have been discovered and been reported just in the French literature in the 1949, and the title here actually is a 65-year-old female with Kendall white spot chorioretinopathy in sarcoidosis, but I think these obviously are not pictures from 1949, but these are our patients' photos. But the description, the pictures back then were very similar to what somebody would see in Birdshot. And sarcoid is one of the great masqueraders of Birdshot retinal choroidopathy. So. What about the second report? Maybe just before Ryan and Mominay, Dr. Hank Kaplan and Tom Auber had described 4 patients aged 40 to 70 years, and they had diffuse posterior choroidopathy with vitritis and retinal vasculitis, and they had decreased central vision due to CME. And the CME might be responsive to corticosteroids in the early course, but and they also describe a lot of choroidopathy associated with pigment epithelium abnormality, followed by electrophysiologic abnormalities. And that was the first, possibly the first couple Birdshot patients until Dr. Ryan Mominay described it. And this is the classic description in their 1980 paper in AJO. You have 13 patients, all white, had white painless eyes and with minimal anterior segment inflammation. And there's these debris in the anterior and posterior vitreous. And they have profuse retinal vascular leakage and with resultant retinal macular and optic edema, and 5 of these patients progressed to 20/200 or worse in at least one eye. Now, Don Gass described another set of Birdshot patients. There are 11 otherwise healthy patients, usually women, 36 decades, and they describe floaters, photopsia, blurry vision, and then most strikingly describe color and night issue, vision issue, and they have lots of vitreous inflammation. They have multifocal patches depigmentation. And also they have variable retinal edema and papilledema, narrow retinal vessels, optic atrophy, and moderate to severe ERG findings. Again, electrophysiologic findings were pointed out. And that's really one of the hallmark of this condition. And their variable rate of progression. And the tendency is that one of the eye usually retain decent vision while the other one goes pretty bad. And they call it vitiligionous choroidal retinitis because the similar appearance on the fundus comes somebody with vitiligo. So 2006, Dr. Ralph Levinson and Dr. Foster included there was a panel of experts that got together and came out with a proposed diagnostic criteria for Birdshot. So you have to have the required characteristics, which have to be bilateral in nature, and they have to be at least 3 peripapillary so-called Birdshot lesions. Usually they're found, especially early on, they found the inferior and nasal to the optic disc. You have low-grade anterior inflammation, usually 1+ cells or less, and you can also get moderate vitritis, 2+ or minus, less. Supportive finding, everybody knows about the A29, but it's still a supportive finding, and some expert will go so far to say that if the patient is not A29, they do not have Birdshot. I mean, it's pretty common finding in Birdshot patients, and they need to, they usually, if they have retinal vasculitis or CME, those are supportive findings. The committee put together exclusion criteria saying that if you have KPs on the cornea, then that's not Birdshot, and if there's posterior synechiae or there's any other systemic infections or autoimmune condition that can result in a Birdshot-like disease such as sarcoidosis and intraocular lymphoma. Now, what can we learn from the original reports? Now we backtrack a little bit to the original report by Dr. Ryan and Momine. There are 13 patients, mostly, more of them are women. KPs, character precipitates on the cornea, were found actually 3 out of the 13 patients, and there's one patient just with one single KP, but it was there nevertheless. Vitreous cells, common, they're 100% of patients, they have that, and vascular sheathing, 3 out of 13 patients, macular edema, pretty common as well, and they have, and it's described by diffuse capillary vasculopathy with profuse leakage. And one of the comments they made here is that systemic corticosteroids were not effective. What about Dr. Gass's report? 11 patients, again, mostly women. He also described KP on the cornea, and he also, being the astute observer as he is, Dr. Gass also saw molten fat precipitates at the posterior hyaloid. And the vitreous cells, their FA shows all these unexplained subnormal fluorescence of the retinal vessels during the entire course of angiography. And then also he noted increased circulation time in these eyes too, with capillary leakage, cystoid macular edema. And then the common point he made was corticosteroids was ineffective. So what can we learn from these? So I think it goes to show that the AJO criteria in 2006 is probably not completely accurate. And Dr. Foster also admits to that. Even since then, he has seen KP in patients with Birdshot. So if everything else looks like Birdshot, the posterior segment, the FA, the ERG, even with a KP, you should probably still give them a diagnosis of Birdshot. And Dr. Herbor, again, he also described granulomatous KP in 3 out of 19 patients in his one of his case series of Birdshot. So KP cannot be an exclusion criteria. So those are the first reports. What about subsequently? So we have about close to 100 publications on Birdshot, at least in the English literature. And we only find that female is only a little more predominant than male. So you almost see 50-50 at a time. And the average age of onset is 53 years, range 15 to 79. And Caucasians are affected almost exclusively. Okay, and that accounts for 1% of all uveitis seen, but about 6 to 8% of posterior uveitis seen in a tertiary referral center. And the 2 biggest masqueraders are sarcoid and lymphoma. And there's also a question of a systemic association with hypertension and cardiovascular disease. Sometimes they say 20 to 25% of the time. So that's really that's something that's just worth mentioning, especially when we talk about Birdshot being a primarily ocular disease. Is something to look out for and ask your patients about when you see next time you see a Birdshot patient. Now, in terms of etiology and immunogenetics, how does Birdshot happen? What causes it? We don't really know. Is this a viral, bacterial? Is there some sort of infection that triggers some sort of molecular mimicry? And we point that out because there's actually been 3 case reports here that these certain infection were actually treated, and the patient looked like they just had Birdshot, and then they treated this infection, and the condition resolved. So there's 3 reports. So we don't know, but it's just a interesting thing to point out. About the HLA A29 association, now A29 is found in 7 to 8% of the general population, but it's found 95 to 100% of Birdshot patients, and that marker alone gives you 50 to 224 times a risk developing a Birdshot retinal choroidopathy. And they're also now with a high resolution haplotyping. We have A29, 01, 02, and 10. Now, A29 is found all racial groups, so how come we only see that Birdshot almost exclusively in Caucasian? So to get there, we need to introduce 2 other concepts here, and I promise there won't be a lot more genetics after this. I know that's too much genetics for me and you as a surgeon. So, but the other concept is a killer cell immunoglobulin receptor. These are receptor proteins that found on the surface natural killer cells. What they do is they regulate the killing function of natural killer cells by interacting with the MHC class 1 molecules. The interaction allows the NK cells to detect tumor cells, infection that usually don't have a lot of class 1 MHC on their surface. So, and what these KIR proteins do is they usually exert an inhibitory effect on the killing function. So they prevent the natural killer cell to attack your own body. Now, there's a few KIR that has the ability to activate cells. So these are highly polymorphic proteins, and the gene sequences are very, very different among individuals. So the different individual has completely different sets of KIR proteins and genes. Now, besides the KIR, I'll tie that together shortly, but the second one is HLA-B44. When you send your patients to do the ABC typing, next time pay attention to B44 as well. B44 has been shown to be found more in people with retinal vasculitis, idiopathic isolated retinal vasculitis, but next time you have a Birdshot patient, look at it to see if your patient has B44. We find that quite often in more than 50% of Birdshot patients. Now, B44 and A29 are known to be in the so-called linkage equilibrium. What that means is, these two haplotypes are tied together more than what chance will allow. And that may have just to do with our evolution. And Dr. Rel Levinson described a subtype of B44 called T80, and basically it's the threonine rather than the alanine in the position 80 on the glycoprotein. And this subtype in particular interacts with the KIR protein surface protein on the natural killer cell. There's these 3 genotypes I'm describing here too, and these are genotypes that are commonly found in Birdshot patients, and they are uncommon in races other than Caucasian. And that's probably the key why we see Birdshot only in Caucasian patients with A29. There's this haplotype here, 3DL1 /BW4T80. That genotype actually gives somebody a 10 times risk of developing Birdshot retinal choroidopathy. So perhaps in the past, the 29, the B44, and a certain type of KIR interact together and protect a population from some sort of epidemic infection, maybe many hundred years ago, and that's why we have a certain population that are more prone to this disease. So that's enough genetics. So in terms of diagnostic testing, the FA is commonly done that show macular leakage, vasculitis, disc leakage, and generalized abnormal hyperfluorescence. CMV is relatively rare. 14% has been reported before, but in our experience, a little less than that, and maybe closer to single-digit percent. And there's a so-called exudative phase where the retinal involvement predominates. And most of the disease, actually, the visual complication from disease actually happened during this time. ICG, of course, shows diffuse hypocyanescent spots visible in early disease. So sometimes when the lesions are not very easily visible on your clinical exam, you do an ICG and the lesion will show up beautifully. Fundus autofluorescence is something that's a little newer. People be using them more in these white dot syndromes. They're using these multi-modality imaging in terms of diagnosing different kind of white dot syndrome, and Birdshot included. So they have found abnormal fundus autofluorescence in 80% of Birdshot patients. So here's a picture of FA and ICG showing hypercyanosin spot. And finally, the fundus autofluorescence. And you can see the author here reported they often see peripapillary hypofluorescence around the optic nerve, indicating dead RPE cells. And the second most common finding is extramacular hypoautofluorescence, and followed by macular hypoautofluorescence. Now, SD-OCT shows macular edema, epiretinal membrane. In chronic disease, there's, of course, the outer retinal layer ellipsoid zone attenuation. And enhanced depth image in OCT may show choroidal lesions that are not apparent on ophthalmoscopy. And this is actually done by the same group that reported the fundus autofluorescence findings. So next time if you had a capability to do EDI OCT, try it on your Birdshot patients. What they found here is that they see these large signal blockage over here. And single blockage over here that there is not apparent on the clinical exam. Like this one, actually, you can see. This one, you can correlate that with the little yellow lesion here. But there's this large hyporeflective lesion here that is not seen on clinical exam, and EDI-OCT can pick that up. And what the author here proposes that it might be a collection of lymphocytic infiltrates that are blocking the vascular marking for the choriocapillaris. Now, ERG, we do this all the time on our patient, and in our opinion, it has to be done on the Birdshot patients. Otherwise, you're really doing them a disservice. It shows that early on, you had the inner retinopathy, which show loss of oscillatory potentials and B-wave amplitude, and late in the disease, you got reduction of photopic B-wave amplitudes, and what we found most consistent across all our patients is you can see progressive prolongation of the 30 Hertz implicit time. In fact, if you give me one page of the ERG, I will ask for the 30 Hertz flicker, because based on the 30 Hertz flicker finding, I can know how well my Birdshot patient is doing. Now, how do you monitor Birdshot patients? Visual acuity alone is never an appropriate monitor, because people can get gray 20/20 vision, but the rest of their retina and choroids are still inflamed, and they can still lose ERG, they can lose their photoreceptor functions. So what is appropriate for monitoring? FA-ICG, OCT, ERG, and also blue on yellow, or so-called CETA swap Humphrey visual field. And you can do that either 24-2 or 30-2. Every patient that comes to Mercy, every Birdshot patient come to Mercy, we tell them to pack lunch every 6 months because they spend the whole day with us. That's the so-called big Birdshot day for them. So in between we see them, if they're getting chemotherapy with us, of course they come in every month, every 6 weeks to get their chemotherapy done in-house, they get their blood drawn, but every 6 months we repeat all these testing. So they can spend a few hours in the clinic just to make sure, because we find that in Birdshot patients extremely hard to monitor. Sometimes you think you're doing great, you think the patient is treated so appropriately, yet they're losing vision. And you always want to ask your patients, how do you feel? You know, if everything looks great, there's no macular edema, there's no leakage on FA, you can still see patient that comes in and say, my contrast color has been a little off recently. And that's actually a sign that their disease might still be active, and you might want to up the aggressiveness of your systemic therapy. Now, here's just a little picture showing the progression in terms of treatment. Once patients go on to immunosuppressives, we have a patient here that leakage got a lot better on FA. And this is also a paper published by our group that shows that even if you catch somebody in early disease or Birdshot, their hyposynessence spots on ICG are actually reversible. Of course, if they're chronic, there's chronic ischemia there, then the spots will always be there. But if you treat them early, the ICG can actually improve. So you can use that. You don't have to do that probably ICG every single time, but it's something to worth thinking about if you next time you have the capability of doing that in the office. Now, this is a patient that we treated with Remicade, and he did great. So Dr. Foster sent him to me to a membrane peel, and he did great after the membrane peel. Now he got his vision back. He's very happy. He's still on Remicade. Now, this is examples of what I meant by implicit time. After treatment, this person's implicit time, usually the normal implicit time is 25 to 30 milliseconds, at least based on the perimeter of our machine. And this guy came in with a really prolonged implicit time. And after treatment, it got significantly shorter. So that's one of the barometers we use to see whether someone is doing well. And the Humphrey visual field, the blue on yellow, which is what usually used to detect early glaucomatous changes, we use in our Birdshot patients too. And this patient, you can see after 6 months of immunosuppressive treatment, his visual field significantly improved. And of course, we look at the field, we look at the mean deviation, just like you would interpret a typical glaucoma field. There's nothing else special about this test for Birdshot patients. Now, so let's talk treatment. So the principles of Birdshot is that it's active for 10 to 12 years. And this is what you can tell your patients too. 10 to 12 years is an active disease, but the first 2 to 4 years are the most aggressive usually. And those are the years that people go blind, and they're forever blind. And the disease self-limited in 20% of the time. But you want to catch those people. You want to, the 80% people can progress, and you want to diagnose them early, monitor them correctly, and put them on the correct therapy. And in our opinion, oral or regional steroids is never an appropriate monotherapy for Birdshot patients. We think the Birdshot patient needs to be on systemic immunomodulatory therapy. And I'll talk about that later. Even people who have Retest put in their eye, in our practice, they still remain on systemic immunotherapy for some time. Now, the longer the disease goes on before you start them on immunosuppressive, the worse outcome they have, of course, but then also becomes much more treatment resistant. And is it because epitope spreading? Maybe some damage to the cells release certain things and make your body even more immunoactive, immunogenic to the retina and the photoreceptors, perhaps. In fact, we see a few patients now that in our clinic that had developed anti-retinal, anti-optic nerve antibodies after they had Birdshot. Now, of course, you can say, oh, we find these antibodies in uveitis patients. But yes, but these patients also behave like they have autoimmune retinopathy. And these are the patients we were actually end up the NT on in terms of their treatment and put them on systemic rituximab. Now, there are just a couple reports here that basically goes to show the Birdshot patients do well after systemic immunosuppressive therapy. Okay, so this one from the Hopkins group, they have 40 patients, a median follow-up of 2.5 years, and they found that incidence rate on follow-up for vision loss of 20/50 or worse or 20/200 or worse were 13% and 4% per eye year, respectively. And the incidence of cystoid macular edema was 10% per eye year. And they found that use of immunosuppressive drug therapy was associated with reduced risk of CME and vision loss. Another group here, that Dr. Foster's group, MSI year, 28 patients, median follow-up 81.2 months, and the patients were treated with cyclosporin, mycophenolate mofetil, azathioprine, methotrexate, and daclizumab. And the authors also here made a comment that long-term preservation of visual function is attainable with systemic corticosteroid sparing immunomodulatory therapy for patients with Birdshot. And they also recommend prompt treatment with systemic IMT, and it can offer, because it will offer the best hope to maintain retinal function, which used to be considered really, really tough to treat, because there are other reports earlier that shows, despite all treatment, Birdshot patients don't do very well. But our view is a little more optimistic than that. I think the key is to catch it early and treat it aggressively. Now, what about specifics, treatments? So Birdshot is a T-cell driven inflammation. It's usually granulomatous, and that's why we see the granulomatous KP, as I described earlier. And so they're very highly responsive to the anti-T cell therapy. So Dr. Foster, back in the 90s, he put people on cyclosporin, systemic cyclosporin for Birdshot. And they thought they were the pioneer. And then later on, he found that Dr. Li Huang from France actually published even earlier, 6 years before they did, but it was in the transplantation literature. So none of the ophthalmologists actually pay attention to it. But Dr. Li Huang was actually we considered the first person that actually used low-dose cyclosporin therapy for Birdshot patients. Since then, Dr. Foster have found that systemic cyclosporin alone is not good enough, because he would have somebody on cyclosporin for 7 years. You're monitoring their kidney function, their blood work, everything. And when you try to taper them off, their disease tend to flare up. So since then, he found that adding an anti-metabolite to the recipe is usually a very effective therapy in terms of getting patients into remission. So here this is our paper here to describe, in our experience at Mercy, the first-line therapy for Birdshot patient is a combination of cyclosporin plus CellCept. And cyclosporin, you can start anywhere between 100 to 300 milligram, and CellCept usually somewhere between 1 to 3 grams, but probably you want to start them on a 2-gram daily dose. And it is not easy, and you might think it's very toxic, but it's really not, because rheumatologists have been using that for a long time. And as long as you had the right infrastructure in place to monitor these abnormal side effects, and you have patients, good communication with the patients. You obviously need to have compliant patients, but usually Birdshot patients, in our experience, are pretty compliant because they're afraid of going blind, and they can tell when there's inflammation. Their vision is all different. So they're eager to do it. You just need to have the infrastructure, or you need to work with the rheumatologist to get them onto one of the systemic therapy. Almost 70% of patients in this case series here achieve inflammatory control by 1 year. And that's by examination of reduced vitritis and geographic leakage, and also improvement on the 30 Hz flicker implicit time. And the combo IMT is usually pretty well tolerated. Now, Birdshot patients have what else? What if the cell segment cycles, or what about the 30% of patients that don't do well on the combination therapy? What if things don't work? Well, so Birdshot patients, there was a paper from Netherlands that in HAO in 2011, they showed that Birdshot patients have elevated aqueous level of interleukin-2, interleukin-17, and also TNF-alpha, interleukin-6, and interleukin-1 beta. So these are some of the elevated cytokines in the aqueous humor of a Birdshot patient. So after somebody fails cyclosporin and cell-site combination, usually we go out to Remicade. And that at Mercy, we usually do it twice as frequently as rheumatologists would do. So we do it anywhere between 5 to 10 milligrams per kilo, and we do a monthly infusion. And then after the patient does well, we stretch it out to every 5 weeks, every 6 weeks, eventually to every 2 months. Once we get to every 2 month level, we then start cutting down on the dose. We used to stretch infusion interval to 3 months, and then we suddenly would stop the infusion altogether. But since then, we have also found in the rheumatology literature that when you stretch it out to every 2 months, which is the typical infusion dose for people with RA and Crohn's, is that if we keep it at 2 months by just slowly decreasing the drug dose, they actually have a better chance of achieving medication-free, drug-free inflammatory control. And we have a paper in Ophthalmology 2013 showing 22 Birdshot patients, including 10 that were treated with eculizumab. I'll bring out why eculizumab is mentioned here in a little bit, but 82% of them had inflammatory control, and 94% had 20/40 vision or better at 1 year. Now, Humira is now approved for posterior uveitis, as you all may well know, but we haven't really had a lot of experience with Humira because we've been treating Birdshot patients with Remicade for many, many years. And usually when they fail the oral therapy, we go to Remicade. So our personal preference is just go to infusion, and you always think, oh, infusion works better than subcutaneous injection, although there's really no head-to-head comparison in that yet anyway. And so we don't know what Humira really is doing for Birdshot patients, but in general, we use Humira. We use Humira a lot in our practice, and we usually do a weekly injection rather than the biweekly. Now, you start out with biweekly, but oftentimes we find that uveitis patients in general needs a little more frequent injections. Now, there's also Actemra, the intravenous subcutaneous formulation is approved for rheumatoid arthritis and juvenile arthritis, and now recently just received FDA approval for treatment of giant cell arteritis, the sub-Q form. We use it for infusion. We use it for infusion at Mercy, and we do our infusion there, and the dose is usually 4 to 8 milligrams per kilo. And there's a STOP uveitis trial underway looking at Actemra for non-infectious posterior panuveitis. Now, IVIG we have used before too, and is actually excellent. It's just that it's very expensive, very cumbersome for the patient. But the biggest case series of IVIG used in Birdshot patient was 37 patients, and that was published in Journal of French Ophthalmology. And interferon has excellent experience. We have excellent experience with them in patients with Behçet's and multiple sclerosis. And we personally don't do interferon very much, but there's been reported in 2 Birdshot patients before. Now, Rituxan I mentioned earlier. We don't usually use Rituxan for Birdshot. We do use it for a lot of other what we think is more of an immune complex, B-cell driven, B-cell dominant diseases like scleritis and Wegener's and polyangiitis and also pemphigoid. But in Birdshot, because we think it's mostly predominantly T-cell, we don't really go to Retest Med. There's been one case in the literature that showed Retest Med was used in the Birdshot patients, and that was also in the Netherlands patient. But the patient was also on mycophenolate and also oral prednisone at the time. Now, we have used it in patients who developed those anti-retinal, anti-optic antibodies that kept on having progressive visual field and ERG changes despite everything else looking great. And that's when we treat them with rituximab. And these patients we have actually been able to stabilize the disease in these patients. Now, I mentioned daclizumab earlier. It's an anti-interleukin-2 therapy. The IV form called Zenipex, we used it years ago when I was still a fellow with Dr. Foster, and it was extremely effective in Birdshot patients. However, because of low market demand, the company no longer makes the IV form, and now you can find the Zimberta, which is a self-injection form. That's for multiple sclerosis, but we haven't really, the couple patients we used it on, it really didn't work very well. Secukinumab or Cosentyx, it's an anti-interleukin-17. Now, as I mentioned earlier, interleukin-17 was also elevated in Birdshot patients' aqueous humor. The IV was also extremely effective when there was a trial drug. It was done with Novartis, and we were part of the participants on the trial, and we found great success, again, because the uveitis was a sort of an orphan disease. The company did not pursue the IV formulation, sadly, so now we have the Cosentyx for psoriasis, and we also don't find it very effective in Birdshot patients. Now, what about surgery? What about Retest? There's two papers here that I'm showing you, and patients have either when they don't tolerate their immunosuppressive therapy, when they don't want to go on to immunosuppressive therapy, or when the doctor is not comfortable with doing the immunosuppressive therapy, then we can, of course, have the conversation about doing Retest and tell them that this is something that will last in your eyes for 30 months. And these two reports here both report pretty favorable outcome on Birdshot patient. They found that one study, only one patient needs to be on IMT after 12 months, and the other study, only 2 out of 11 patients with Birdshot were on IMT at 3 years out. Now, what these authors found was that a lot of them require glaucoma surgery, more often than what you would typically expect in Retest patients who receive it for posterior uveitis, at least based on the MUST trial. Usually in the MUST trial, you tell people, man, 70 to 80% IOP elevation, maybe 40%, maybe half of that needs glaucoma, incisional glaucoma surgery. But in these case series, there's more people with glaucoma surgery need, and why? Is it because maybe Birdshot patients don't usually come in treated with topical steroids? Usually it's a pretty easily recognizable, it's posterior uveitis, so and anterior inflammation is usually not super severe, so maybe the referring doc don't put them on steroid drops, so you kind of then maybe in a way you're missing out the possible steroid responder. So that's a thought. Now, neither of these studies have use visual field or ERG as outcome measure of their whether they're getting the disease control or not. The paper on the left from Dr. Davis' group, they have collected visual field data and ERG data, but because there's such a variable acquisition, they're done on different machines, they never end up analyzing the data. On the right, the authors here from Hopkins did not collect any visual field ERG at all. Dr. Foster published this just 3 years ago, and we had 11 patients that also underwent Retest insertion, and we found that the inflammatory control was obtained, and that's based on visual field and ERG finding at 90, 89, and 100% of patients at 1, 2, and 3 year respectively. And at baseline, almost a little more than half the patients were on systemic immunomodulatory therapy, and that decreased to 14% of it 3 years after Retest. So why are they still on immunosuppressive therapy? And that's what brings back to my points earlier. Birdshot patients, you just never know. With steroids, and we never use Ozurdex to treat our uveitis patients because that's a very short-term treatment, and it is the intermittent inflammatory flare-up that really rob these patients of their vision. So we don't use Ozurdex ever, unless there's uveitic macular edema and the inflammation is under control, then that's another story, but we don't do it just for the sake of controlling inflammation. So even for Retest patients, we think it has to be, you have to monitor their ERG, monitor their visual field, because the FA will probably look great, the CME will be gone because you have the Retest in the eye, but their electrophysiologic and also functional visual field can still change, and you have to monitor them. That's why some of our patients are still on systemic IMT. Now, in this study, we also find a little more elevation in the IOP, and 4 patients require glaucoma surgery, which is similar to what we expect based on the MUST trial. So, in summary, Birdshot retinal choroidopathy is relentlessly progressive, and it's without early immunomodulatory therapy, it is extremely blinding. And we don't find steroid monotherapy to be appropriate ever for this condition. And visual acuity is never sufficient for monitoring, and we have to do the other tests all the time, every 6 months at least, and just do it and find you can catch a lot of active disease by doing that. And our recommendation for therapy usually is starting with some sort of anti-metabolite plus cyclosporin. And if that's not effective or tolerated, then you can move up to the biologic agents. And in our experience, IV therapy is more effective than subcutaneous injection. And finally, Retest is a good option as long as you're monitoring and make sure there's no deterioration in the visual field and ERG. So thank you very much.